Hey everyone, my name's Andy Hahn. I'm an assistant professor of genitourinary and medical oncology at MD Anderson Cancer Center in Houston, Texas. And I'm going to be giving you guys a recap of some of the top studies that were presented focusing on kidney cancer this time at the ESMO Congress that was in Berlin in October of 2025. I'm going to try to highlight 5 different studies during this. None of these are meant to be exhaustive. They're designed to pique your interest and have you go watch the full presentations and go learn more. And some of these I know have been published as well. Okay, so first we have an industry-sponsored study by Dr. Christina Suarez. This is substudy 03A of the phase 1, phase 2 Keymaker U03 trial. And so this trial was for patients with clear cell or renal cell carcinoma, and it was evaluating novel combinations as first-line treatment for metastatic clear cell RCC. And all of these were using a pembrolizumab backbone and adding more treatments on top of it. The control arm for all of these was lenvatinib plus pembrolizumab, which is already approved. And a total of 353 patients were randomized either to that control arm or one of 4 novel combinations. And these combinations included a lot of different things. These included LAG3 inhibitors, CTLA4 inhibitors, PD-1 checkpoint inhibitor pembrolizumab, HIF-2 alpha inhibitor belzutifan, and multi-target receptor tyrosine kinase inhibitor, lenvatinib. There's a ton of data in this presentation, and I'm not going to go over all of it. It was published simultaneously in Annals of Oncology. I think the most promising novel triplet combination was the triplet of pembrolizumab plus belzutifan plus lenvatinib. So adding belzutifan into our pre-existing backbone. So for this combination, the median progression-free survival was 31.8 months. And when that was compared against the control arm of lenvatinib plus pembrolizumab, it was associated with a 55% reduction in the hazard for disease progression or death, which is really promising. Now, this is phase 1. It's an early study. The numbers are big for a phase 1 study, but I think the main purpose of this presentation in my mind is that it creates a lot of excitement and enthusiasm around the ongoing LIGHTSPARK-012 trial that we're waiting to see the results of this triplet combination compared to standard of care. All right, so the next oral presentation that we're going to cover is the OPTIC RCC study presented by Dr. Hack and the team at Vanderbilt University. So this was a really cool study. It's a totally new way of approaching renal cell carcinoma. This was a phase 2 trial, and it used a machine learning model based upon the InMotion 151 RNA-seq cluster. So there were a bunch of clusters here that they assigned to patients to in a post-hoc analysis. And then for this study, they're randomly assigning patients based upon the gene expression cluster that they fall into. And they're going to different previously approved first-line PD-1 based combinations. And so here at the ESMO Congress, they've presented the results from patients who are in cluster 1 or cluster 2. These are the angiogenic clusters where patients have previously been shown to better respond to angiogenic targeted therapies. And the patients who went into these clusters were assigned to nivolumab and cabozantinib and compared back against historical controls. So by using these RNA-seq clusters, which we've never done before, it resulted in a numerically improved objective response rate compared to historical control with nivolumab plus cabozantinib. The objective response rate was 71%, and none of the patients who had this angiogenic cluster experienced primary progressive disease, which is very encouraging. Now, the numbers are small. This is not a definitive approach. And there's a number of things that we're going to have to consider when we think about taking RNA-seq-based gene expression clusters into the clinic, but it's thought-provoking, and we're all waiting to see more of the cluster results in the SIGN treatments and see how they perform against one another. All right, so the next study I'm going to cover is one that I presented. So this was our LenCabo trial, which we've simultaneously published in Annals of Oncology. And so LenCabo was a phase 2 investigator-initiated trial that randomized a total of 90 patients who were progressing on a PD-1 checkpoint inhibitor combination. So this was either nivolumab plus ipilimumab, pembrolizumab plus axitinib, or adjuvant pembrolizumab and recently stopping and progressing. And those 90 patients who had that type of disease progression were randomized to either lenvatinib 18 milligrams plus everolimus 5 milligrams versus cabozantinib 60 milligrams. And patients were stratified at randomization based upon their IMDC risk score and whether or not they had previously received an angiogenic targeted therapy. The primary endpoint for Lencabo was progression-free survival, and the combination of lenvatinib plus everolimus significantly reduced the hazard for disease progression by 49% compared to cabozantinib. For secondary endpoints, objective response rates were numerically higher but not statistically different between the two groups, 53% for lenvatinib plus everolimus compared to 39% with cabozantinib. And the overall survival was immature. This analysis is ultimately very inconclusive. The study was not designed to answer that question. We did see differences in the adverse event profiles for the two combinations. More patients experienced grade 3 or higher treatment-related adverse events, serious adverse events, and had treatment discontinuation due to a related adverse event with lenvatinib plus everolimus, but more patients interrupted dose or reduced the dose with cabozantinib, and there were differences in the AEs that patients experienced. So overall, I think this, again, not a practice-changing trial, but this is very practice-informing. It's a problem that many of us encounter in clinic and shifted the way that I was thinking, and I think a number of my colleagues were thinking here at MD Anderson, Moffitt Cancer Center, and the University of Virginia. All right, moving on to the next oral late-breaking abstract presentation. That was presented by Dr. Larkin. This was the Rampart trial. So the Rampart trial was a phase 3 trial that randomized patients with resected renal cell carcinoma to one of 3 arms in a 3:2:2 ratio. And those 3 arms were either active monitoring, durvalumab for a year, which is a PD-1 checkpoint inhibitor, or durvalumab plus tremelimumab, a CTLA-4 inhibitor for a year. So they randomized a total of 790 patients. And then for this analysis, they're only focusing on the durvalumab plus tremelimumab arm versus the active monitoring arm. And this PD-1 plus CTLA-4 checkpoint inhibitor combination was associated with a statistically significant 35% reduction in the hazard for disease recurrence compared to active monitoring. So we don't know the results of overall survival. We also don't know the results for the adjuvant durvalumab alone arm. I'm sure that data will be presented in the future. For this study, I think very interesting results, but given the approval of adjuvant pembrolizumab, where it significantly improved overall survival, I suspect that we're going to need to await the overall survival results as well as that durvalumab monotherapy arm before deciding upon how much this is going to impact our clinical practice. Okay, final one from the rapid orals. Just wanted to give a shout out to Dr. Katie Beckerman, the team. This was when she was at Vanderbilt. This was a phase 1, phase 2 clinical trial evaluating a novel triplet therapy building upon a nivolumab plus ipilimumab backbone by adding in ciforadenant, which is an adenosine 2A receptor antagonist. And this was all designed to be first-line treatment of metastatic clear cell RCC. And so this is a multi-center investigator-initiated trial of 51 patients. Primary endpoints for this were safety and for the number of patients achieving a depth of response greater than 50%. And in total, 32% of patients treated achieved that depth of response of greater than 50%. The objective response rate was 46%. About 20% of patients experienced primary progressive disease, and the median progression-free survival was 8.5 months. The combination of this triplet showed an acceptable safety profile, but in sum, the efficacy data was not thought to meaningfully improve upon the backbone of first-line nivolumab plus ipilimumab. I think this investigator-initiated trial, it should be applauded for trying to push the needle and bring novel mechanisms of action into the clinic for patients with metastatic clear cell RCC, but it also highlights the challenges that are ongoing with development of novel triplet therapy regimens using an nivolumab plus ipilimumab backbone. Thank you. That's all I have from Berlin here for renal cell carcinoma. You can also check out our overview of prostate cancer that's been posted. Thank you.